presence here this whole day, and I'm glad to go ahead and announce our next speakers. Our first speaker for this afternoon session is Dr. Renata Savage. Dr. Savage is a professor of pediatrics and is a neonatologist. She's the chief of the Division of Neonatology and Newborn Services at the University of Mississippi Medical Center in Jackson, Mississippi. She has an extensive involvement in global health. She's on the American Academy of Pediatrics Steering Committee for Helping Babies Breathe and has recently been adopted as the AAP liaison to Ethiopia. So it's my pleasure to introduce Dr. Savage, who will be talking about improving neonatal mortality in the world using NRP and the Helping Babies Breathe program.
Good afternoon. I'd like to thank everyone for inviting me to speak this afternoon. I'm going to talk about something that's not adult acute care. It really starts with the very beginning of life, or the neonatal mortality that we see around the world, and the vast majority of which is preventable mortality. So the World Health Organization estimates that 1 million babies die each year from birth asphyxia, or not being able to breathe immediately after birth. Another 1 million babies die each year from prematurity, and another 1 million babies die each year from infection. So those numbers are huge compared to the recent attention that has been paid to the Ebola crisis, or even HIV, or even car accidents around the world. So the AAP, Helping Babies Breathe, and essential care programs address this challenge, as well as helping to move forward the Millennium Development Goal number 4, which is a reduction of child mortality by 2/3 from 1990 to 2015. Now, those of you may know, we're in 2015 and we have failed horribly at this goal. We are so far off from where we wanted to be back in 1990. And so the other part of it is infant mortality has improved worldwide, mostly with paying attention to diarrheal diseases. Neonatal mortality, or the percentage of neonatal mortality, has vastly increased. So again, we've all seen these pictures of how dire things are in sub-Saharan Africa and Southern Asia for the baby's a higher risk of dying before their 5th birthday. So again, you can see where we need to concentrate our efforts worldwide. And I have to say, having just moved to Mississippi in the US, we need to concentrate our efforts in the South. We're not doing so well there either. So again, when you look at the worldwide causes of neonatal death, preterm birth, severe infections, and asphyxia cover the vast majority, and we can do something about all of these areas. So we know when babies are first born, number one, in sub-Saharan Africa and Southern Asia, the vast majority are born at home, away from physicians or actual midwives. Many of them have only birth attendants or their neighbor to help assist in the delivery. But thankfully, for most babies at birth, they just need assessment and routine care, so 80 to 90% worldwide. Some babies need a little bit extra: drying, warmth, clearing the airway, and stimulation. These are things that can be easily taught but are not typically done. And then another subset, about 3 to 6%, need bag and mask ventilation to make that first breath effective, or to implement that first breath. And very few actually need the complicated resuscitation that we do in the United States with chest compressions and medications. But the challenges of teaching all of this in resource-poor developing countries are that there are limited medical facilities for deliveries. There are very few people that are trained who attend births. The skill level and literacy of those providing care is very low. Oh, this one's working out, okay. That we need to maintain the skills, so it's not enough just to parachute in, teach people how to do this, and then leave and think they're going to retain those skills. We need a supply chain for the equipment and how to resupply. We need a way to collect the data to make sure we know that we're doing a good job and that we're effective. Quality improvement and assessment. And then we have a lot of cultural awareness and differences that we need to overcome. Do they have certain things, like putting cow dung on the umbilical cord, that we need to interact with in that local area to make sure that doesn't happen? There's a lot of inefficiencies in the government, and then the own governmental self-perception of the medical system. They really don't love it when people from the United States say you're doing terrible and this is what you need to do. They often want us to do the high-tech things, and that's not where we need to focus. Having said all that, we've been very successful in the AAP neonatal resuscitation program, developed by AAP, evidence-based, has been used for 30 years, especially in the developed world. used in high resource settings, and it really teaches those first initial steps of resuscitation. But we felt and we realized this was not going to be very effective in the rest of the world where the majority of neonatal mortality was occurring. So we needed to develop something in limited resource, so a global development alliance combined. Unfortunately, we are pretty well funded with AAP, USAID, NICHD, Save the Children, Laerdal, and then support from the Latter-day Saints. So we do have pretty good funding to implement this around the world. And so this is a suite of teaching modules, but it's a whole program. It's a whole country program, helping babies breathe, so to assess and implement and interact with people that are having that initial first problem with breathing, essential care for every baby, so really teaching about the first day and the first week of life to interact and implement change. And then to a module we're just developing right now is essential care for small babies, to really get those late preterm babies and how to deal with them and deliver medical care to save their lives. So again, this is an example of a baby born in sub-Saharan Africa, not breathing. Baby eventually died because people there at the delivery just did not know how to do simple things to start that first breath. So again, for helping babies breathe, to make sure that babies have a skilled birth attendant in every delivery so we can reduce mortality due to asphyxia, we need to go into the countries and collaborate. It really does not work just to go and teach without setting up that infrastructure because it cannot be maintained. We're realizing this and we're doing that on a global level, but we're really focusing in a few countries, and I'll tell you more about that. It needs to be country owned and led. We might have the skill to teach, but they need to carry that on. Integrating with maternal and essential newborn care, so what they do in that country already. And we want to make sure that everything can be used worldwide, so everything is available on the HBB website from the AAP. So the concept is it's pictorial, so even if you can't read, you can teach it to somebody, limited text, hands-on performance, frequent skills practice, the simplest steps possible, and for HBB, teaching the golden minute. That first minute is crucial. So again, here are people that are learning, so we have gone to other countries, in-country taught people how to do these skills. You can see the flip chart that's used for the teaching. They're very simple mannequins that are not super expensive by US cost, but maybe expensive throughout the world. Again, they all have an action plan, so pictorial, showing all the learners what they might encounter and going down an algorithm, what they need to do in each step. So again, very easy to understand. Again, routine care, just clearing the airway, drying, keeping the baby warm, cutting the cord, encouraging breastfeeding, teaching all these steps in a very systematic fashion and making sure that people understand and can practice this. Then the golden minute for if a baby is not crying or breathing, how to clear the airway, stimulate, and initiating ventilation with a very simple bag mask bulb syringe system. Again, really, is the baby blue and not crying, not breathing? How can we convert that baby to a baby that's breathing? There are learner workbooks that are with this entire module that the learners take home and use to practice, again with pictures, teaching each other, so this paired methodology of education is very important. They do exercises so they can reinforce their skills, and then using a very easy simulator that mimics a baby that can just be filled with water and is very tough and can last for a long time. Again, doing pair learning and teaching, and it can be taught all over the world, and these materials are adapted in many, many languages. And it's sustainable, it's low cost, it's effective, it's easy to integrate into the current health system. Again, some studies have come out. It is effective. It's decreased neonatal mortality. It's decreased stillbirths, which used to be babies that didn't breathe, so they were all counted as dead. So again, toolkit has the action plan, the workbooks, the flip charts, practicing, simulator that's included in the kit, and then very simple materials that people can use to resuscitate. I'm just going to mention the last two modules, the essential care for every baby. So again, taking that first resuscitation and expanding it to the first day. What do people at the bedside or in the home need to do to keep that baby healthy for that first week? Initiating breastfeeding, cord care, skin to skin, temperature control, giving vitamin K, and knowing when a baby's sick. And then finally, we are now just rolling out this final module the essential care for the small baby. So using the same methodology to teach and treat the late preterm to allow that baby that's 34, 33, 35 weeks to survive in countries where they might not survive now, but with some simple techniques can survive and live a very long time to show up for the acute care in the ER that you all are teaching about. So again, we're going to be doing that course in July. So thank you very much for your attention.
I'd like to go right on to our second speaker, Dr. Abigail Henkin-Way. Dr. Henkin-Way is an assistant professor in the Emory University School of Medicine, and she holds adjunct appointments at both the Emory School of Nursing and the Emory University Rollins School of Public Health. She also leads a large-scale HIV testing and linkage to care program in the Grady Health System Emergency Department, and her talk will be about emergency medicine, a new frontier in the battle against HIV.
Thank you very much. Thank you all for being here, and thank you for the opportunity to speak. I'm going to talk about emergency medicine, a new battleground, a new frontier in the battleground against HIV. The problem we're going to speak about today is that 19 million people worldwide who are living with HIV do not know their status. And the solution I propose is to integrate HIV testing into emergency medical care across the globe. So here we are on a beautiful day in Atlanta, but not even a mile from here. The emergency department where I teach and where I work clinically resembles in many ways emergency departments across the world. Patients who come to our public emergency department in inner city Atlanta often are quite poor. They may lack medical literacy. They may lack access to a physician or insurance. In these circumstances across the world is what leads people to access emergency medicine, often waiting even at Grady for up to 12 hours to see a physician. We know that these circumstances, poverty, lack of education, lack of access to resources, low health literacy, they overlap with risk factors for HIV transmission. This map of HIV in Atlanta demonstrates that overlap. As you can see, quickly to orient you, the light yellow areas are up to 100 people with HIV per 100,000. The dark purple areas towards the middle, which in the kind of at the center of which is where we are right now and where Grady Hospital is, those are upwards of 6,000 per 100,000 to as much as 8,000 per 100,000 in some zip codes, and actually far higher when you zoom in on certain demographics. To put that in a global context, 8,000 per 100,000 population puts us similar to the population of Uganda as far as HIV prevalence, and actually far higher prevalence than many countries in the world. Knowing about the overlap between risk of being a patient at a public emergency department and the risk for HIV, in the summer of 2013, we instituted a routine HIV testing program in the Grady Emergency Department and Primary Care Center. We know that testing and treating are actually a model for eradicating HIV. This has been shown in certain populations and computer modeling globally. As people are diagnosed, just the act of diagnosing someone changes their behavior such that they're less likely to engage in behaviors that put them at risk for transmitting HIV. But diagnosing them and getting them on medication actually can bring the viral level in their blood down to nearly zero, so that even if they slip up and do engage in those behaviors, then they're a 96% reduced chance of transmitting HIV. In our program at Grady, over just under 21 months, we tested 37,000 people. Among those, we've identified 300 people who are verified new positive diagnoses, and nearly half of those patients have AIDS on the day we diagnose them. So a healthy individual has a CD4 cell count of about 1,000. To get a diagnosis of AIDS, you have to have a count below 200. That takes about 8 or 10 years of infection. It's not uncommon for us to diagnose people and find out that their CD4 count is about 20. And we've had one patient whose CD4 count on the day of diagnosis was 2. Of those patients, 216 are already linked to care. That means they've seen a provider who has prescribed their HIV medication. and the rest we are actively working with to get into care. We are part, and Dr. Moreno, who spoke earlier, are part of FOCUS, collaboration worldwide, which is a public-private partnership with Gilead Sciences. And we are in 16 cities, 107 sites, who've done 1.65 million tests. So these are different sites with different cultural challenges and different even governmental challenges, but they're succeeding in doing what needs to be done, which is identifying people and getting them in care. Reaching the undiagnosed is critical. Each of these patients is somebody's parent, is a worker who's economically productive, is a person who hopes to be a grandparent and watch their kids graduate from school, is somebody with a future that we can connect them to through testing and treatment. I'm actually going to spend about 60 seconds. Sorry. There's a short video, but essentially this patient on the left is the same person as the patient on the right. What separates these two people is 90 days of antiretroviral treatment. If you think about that and the impact that we've made through our emergency department testing program, you can imagine that these 300 people are not just numbers. Their lives, their economic impact, their impact on their family, their impact for their kids. But then if you take that and extrapolate that, what happens if every emergency department in Atlanta is doing routine testing? What happens if every emergency department in the country is doing routine testing? What happens if every emergency department across the world is doing routine testing? Then we're actually changing the world. We're saving lives every day. So back to the problem. 19 million people living across the world do not know their HIV status. And the solution is to integrate HIV testing into emergency medical care across the globe. Global emergency medicine is a science of meeting people when they need help and providing them the right care at the right time. Providing health systems in disasters or even in day-to-day personal disaster situations. It's the moment when a patient says to somebody, I need help. Can you help me, doctor? And that doctor can provide not only quality care, but a one simple test that can save their lives and secure their family's future. Together, we can do this. Thank you.
I'm going to bring up our third speaker, Jesus Vega. Jesus is an EMT. He started his way into medicine by becoming an EMT in the Red Cross in Mexico in 2008, and then started medical school in 2009. He's now a senior medical student in Mexico, and he's been involved with PACE-MD, the program Dr. Haywood Hall talked about earlier this morning, since 2011. He's now the PACE Corps manager and is helping to bring more students to be involved with PACE-MD, and his talk is about recruiting healthcare students for social impact.
Hi, good afternoon, everyone. First of all, I want to thank you for being here. Thank Dr. Haywood Hall and Mrs. Blancotero for having me here today. And a lot of people in the PACE office back there that couldn't be here today, but they have a lot of credit for this. So as you heard, this project is about students at the beginning. But now we know that the students are the first step for this program, but entrepreneurs in healthcare involves more people that could help us in this project. And this project was born with the philosophy of PACE, to have emergency training at all levels, starting from that person that maybe is a family member and sees his father or his grandfather with a stroke and knows what to do, and get to the specialty doctors that can use the highest technology and know how to triage and treat these kind of cases and try to down the mortality. CORE is a Spanish acronym that involves training, opportunities, challenges for students and now for entrepreneurs that we think it's a good strategy to bring all of those ideas that try to bring emergency training to everyone who is involved. So this is the situation in Mexico right now. It's kind of concerning. There are a lot of EMTs. Most of them are basic, but they need adequate training. Sometimes they finish 1 year of training and they need to learn more skills that they don't know. There are 200,000 physicians, and most of them are general practitioners. This means they don't have any specialty, and many of them are in the ER rooms treating patients. Most of them train because they have the experience of previous courses, and most of them don't know that, I don't know, in AHA in 2010 changed the guidelines. Many of them don't know that. So it's kind of concerning. And there's no data about first responders. You go to Mexico and see the people in there, and they don't know what to do in case of an emergency. It's kind of concerning. There are 2 emergency numbers, and they don't remember one. So the culture and educating the people in their families is a big step that needs to be done in Mexico. So PACE course started in the University of Celaya, the university where I come from, and I started thinking about, well, there are many doctors that are not interested in teaching others these kind of skills, of life-supporting skills, or they don't know that they can teach. But there are students that are interested in. And those people that you see there are plenty others that couldn't be in that picture. They are now instructors of BLS, ACLS, PHTLS, and they have proven a lot of doctors that they're involved with, then they can teach other doctors and even specialties the necessary skills to bring basic attentions in case of emergencies. So this PACE Core program is developed for social entrepreneurs. It's not just the training. It's having the ideas that they can offer and use them so we can improve the attention of the medical emergencies in Mexico, and we hope around the world if this idea heads up. I have seen publication in Sweden and in Brazil where they have seen that students can help in this kind of stuff. And if you go to Mexico, you will see that many firemen are not trained in basic life support skills. And they had to be, because they're in contact with all those people. A lot of EMT, basic EMTs, are trained under old guidelines, and they are helping people, but they don't have the necessary training, and that's concerning. And there are two big obstacles down there. One, for the EMTs, most of them are volunteer, and the ones that earn money earn around $60 for 2 weeks of work. So they can't afford this kind of training, and this is what we are trying to change. We want to give them the opportunity to get training and to teach others these kind of skills. And the doctors who can afford these courses are not interested into. So it's worrying. So the training is based in international standards, AHA and AMT, the AFP, sorry, and opportunities for they to develop their own ideas, challenged because they have to learn to first the skills to save this kind of lives, and they have to learn to teach. So it's a real big challenge for them, and they are gonna get the title of agents of social change, because what they do is going to have a really big impact in the community. So we're recruiting and developing entrepreneurs to create this group of agents of social change that have humanitarian vision aimed to primitive community, where they are able to solve medical emergencies and teach others involved in the pre-hospital and hospital emergency care. And this is the way we are trying to do this. So they are getting training helping babies breathe. They are getting training in BLSO, AHA courses. This is all life support courses that can be learned in a weekend, but this is not about just teaching or having providers. It's those providers being able to teach the courses. So we are gonna have contact with them for a lot of time, and they're gonna be able to improve every time they have the chance to teach one of those courses to other people. So if you imagine that you have a 50-person BLS course, and from those 50 persons, you have 10 people that may be EMTs, basic EMTs, but they have the heart and the courage to say, hey, I want to teach other people this kind of stuff, but I don't have money. I don't know what I have to do. Or you might have doctors that have the money, but they don't have the platform. So PACE is that platform. We are trying to have them in our network and become them instructors, and they can even earn money in some courses and be in the community giving free courses. A big example is what we did in Chiapas last year. We, in one weekend, all students teach around 300 people basic CPR skills. And there were this course of BLSO and helping babies breathe for another around 200 people. So if you take a look at us, this is a chain where PACE has the platform in most of the 31 states of Mexico. And if we have one PACE Corps member in each state, they can build their own little network, and that way we can help the community, starting from Mexico. But I think this can be applicable for a lot of countries that have emergency care crisis that we have been talking about all this day. So thank you very much for your time.
I'd like to introduce our next speaker, Dr. Amaro Alejandro Baez. Dr. Baez has a long history of being involved in emergency medicine for over 20 years. He was trained in emergency medicine at the Mayo Clinic. He had a fellowship in trauma critical care at Harvard, and did multiple master's degrees in public health and also in healthcare management and policy. His talk today is going to be about bridging the quality and technology gap about medical tourism with a social responsibility. Dr. Baez.
Well, good afternoon, everybody. I want to thank Terry and Haywood for extending the invitation and the opportunity to be here today. Let me ask the group, how many are familiar with the concept of medical tourism? Medical travel and medical tourism. All right, good. So, in the process of this talk, I'm going to elaborate a little bit on how I got involved with medical travel and medical tourism, and describe to some extent what I think are the unique opportunities that lie within medical tourism for system fundings and something that we call medical travel with a social responsibility. So our objective is to present a proposal of a value-based, patient-centered, emergency and critical care medical travel platform, what we call a medical tourism with social responsibility. So about me, I am a citizen of the world, so talking about global health is kind of interesting. I was born and raised in the Dominican Republic. I left DR back in 1999 to pursue opportunities in training, stayed in the States for 11 years, moved back to the Dominican Republic, worked on systems development policy, healthcare management and such for about 5 to 6 years, and then returned to the States. I currently work in Miami. So I joke that after working 5 years with the Boston system and 5 years in the Dominican Republic, Miami kind of became an interesting middle point from a culture, from an emergency medicine development, and from an opportunity standpoint as well. I do like the fact that I love Cuban coffee. And there are a lot of interesting Hispanic culture elements in Miami. So Dominican Republic is quite interesting. The city of Santo Domingo is the first city, European settlement on this hemisphere. The Hospital San Nicolás de Bari, the picture that you see on your left, is the first hospital built on this hemisphere. And it's in the city of Santo Domingo, built in 1519. So a lot of people think Dominican Republic and think beach and vacations and resorts and such. The Dominican Republic houses about 10 million Dominicans, about 2 million Haitian diaspora, and about 5 million tourists every year. So we're talking about a captive population of about 17 million. So in the States, I was blessed with a lot of unique opportunities, and I'll talk about two specific very eye-opening experiences that I had. One was by training at Mayo Clinic. I learned great medicine, and I'm very grateful for that, but I also learned the basis of patient-centered healthcare and patient-centered medicine. Dr. William Mayo said more than 100 years ago that the best interest of the patient is the only interest to consider. While working with the Harvard system, I got the opportunity, I trained and worked within the Harvard system for about 5 years, met a lot of interesting people, unique people, and in 2007 I met and trained with Dr. Michael Porter, the person who's actually pushing for value-based healthcare delivery. To me, that was the most eye-opening experience from a health system standpoint. Value, it is the exact equation that we need to bridge the gap between clinicians, physicians, and administrators. Value merges outcomes and quality and cost. So when we talk about medical travel, medical tourism, the things that we are proposing is precisely to develop a value-based, patient-centered platform. So medical tourism is just, in essence, travel. When you have a patient that travels outside his or her geography to pursue care. You have intra. So for example, when somebody from rural America goes to the Mayo Clinic or goes to New York Presbyterian or goes to the Brigham and Women's or Mass General Hospital, that is in essence medical travel. A lot of people talk about international, so the big focus recently is on international medical travel and medical tourism. And social responsibility, we just need to highlight that when we talk about social responsibility is the contributions of any kind of enterprise on social and economic development. So one of the things that we're pushing for recently is to change the paradigm from the semantic of medical tourism and focus on what we call the globalization of healthcare, global healthcare. So there are a lot of research opportunities. For example, if you expand your a multi-center, multinational research trial, basically, your ability to generalize your results within a global village is more important, right? So we look at research, we look at education. I am a product of that. I was born and raised in the Dominican. I trained in medical school in the Dominican Republic, and I work in the United States. So education offers a lot of interesting opportunities. Continuing medical education and even doctoral degree education. And the medical care piece is medical tourism, medical travel. And we'll talk about how I think medical travel is an amazing tool to actually promote system growth, quality of care, and better health care in a developing country. So talking about GDP, everybody knows the United States has great medicine in terms of quality and technology, but in essence, it is the most expensive health system in the world. 1 out of $7 of the GDP is utilized in healthcare. Whereas when we look at that cluster on that picture underneath, it's just a bunch of Caribbean countries. When we look at that cluster, we see Dominican Republic, we see Antigua, Trinidad, Tobago, Cayman Islands. We're talking about a 5% of the GDP invested in healthcare. What we believe is that through medical tourism, we can actually fill that gap. We can actually bring it more to the center. We can actually reduce costs overall, even in the United States, and actually inject funds into developing systems like the Dominican Republic. So in the United States, outbound medical tourism is pretty popular, pretty famous. Recently, a hot topic rather. With the healthcare reform, folks are talking about outsourcing medical care because healthcare reform talks about reducing costs and at the same time increasing access in the most expensive health system in the world. So to some extent that is a little bit difficult, but it offers an opportunity for developing outsourcing systems like medical tourism in general. But one of the things that we need to highlight is that medical tourism is not just about cost. It's not just about reducing costs. A lot of people think that the main driver for medical tourism is cheaper care. But obviously in Spanish we say lo barato sale caro. Cheap things end up being more expensive. But if we look at the 3 examples here, these are heads of state, celebrities that have an immense wealth, and they pursued medical care outside of their country, not necessarily because of cost, but actually for innovations and such. So let's talk about 3 cases, or 1 case as it applies to 3 countries. 29-year-old female, worst headache of her life, ends up having a subarachnoid hemorrhage. I had a case like that was medevac from Antigua. Antigua has a similar GDP than the Dominican Republic in healthcare, but it's a country of about 80,000 inhabitants. One hospital, Mount St. John Hospital. So because of scale, because of volume, Mount St. John cannot have all the technologies that a country of 17 million people in any given year have, right? But the same thing happens in rural Dominican Republic. In rural Dominican Republic, because of cost, access, and insurance, somebody with a subarachnoid hemorrhage might not have access to the technologies of invasive neurology and neurosurgery and stuff. And you look at urban Dominican Republic. In urban Dominican Republic, because of lack of insurance, you will also have folks that have the same condition but might not have the ability to access that type of medical care because of lack of insurance or lack of funding. So what we talk about is that through medical tourism, you can actually inject funds, improve quality, and improve systems in general. One of the things that I think also is worth mentioning is in Haiti, we realized after the Haiti earthquake, where we built a network of 2 field hospitals, so about 5,000 Haitians after the earthquake. And one of the things that we realized is that when you compare the Chile earthquake to the Haiti earthquake, you talk about an enormous difference in terms of outcomes, right? And a lot of it has to do with investments in system infrastructure, and the health response, healthcare system component is very important. So by having funds injected into the healthcare system, you also improve the ability to respond to natural disasters. All right, so to finish my talk, because I got the stop button about 2 minutes ago, but since I'm the last, I can get away with all these things, right? Look at Terry. So we want to propose the creation of a value-based patient-centered regional Caribbean emergency and critical care network. One of the things that we talk about is creating an emergency and critical care cluster in the region. So the smaller islands and the many other countries that form the Caribbean Basin and Central America create a network where by forming economies of scale, you can feed each other. You can support each other from a technology and quality standpoint, integrate existing resources, generate economies of scale. You can create knowledge and quality transfer, reduce brain drain. I'm an example of that. I have 70% of me is in the States. The other 30% is kind of staying in the Dominican Republic. So I'm almost one of the brain drain examples. All right. So to finish, the people that know me know that I like art. This is somewhat of an interesting slide. Picasso, before becoming a Cubist, painted this when he was age 16. It's called Science and Charity, Ciencia y Caridad. The original painting wanted to position the physician next to the nun in the same angle and kind of morph it, and he separated charity from science. And interestingly, Dr. Bernie Lown, a Nobel laureate, physician, cardiologist, I had the pleasure of meeting him when I was at the Brigham, also known for inventing a little medical concept called defibrillation. So he said that now the doctor, by virtue of accepting science so totally, creates a total imbalance forgetting the art of healing. So I believe medicine has lost its human face. So I think there's a lot of things to reflect upon, and this is a bit of an eclectic talk, but what we wanted to present is that developing systems need ways of being funded. And there are interesting ways through a medical tourism global healthcare platform that this can happen. So thank you so much, and I apologize for extending my talk.